So at this meeting, there were 3 different abstracts with KEYNOTE 365, one of which was a combination of pembrolizumab with enzalutamide, another pembrolizumab with docetaxel. I presented data on cohort A of 365, which was a combination of pembrolizumab with olaparib. And this was in a patient population that had received prior docetaxel for metastatic castration-resistant prostate cancer, and you could have received up to 1 other line of chemotherapy and up to 2 lines of second-generation hormonal therapy like abiraterone and enzalutamide. So it was a post-docetaxel state. We saw a pretty heavily pretreated population with 41% with visceral disease. So it was a poor prognosis population, and it was molecularly unselected. So we did not mandate that patients had homologous recombination deficiency or microsatellite instability. Treated patients with pembrolizumab IV every 3 weeks and olaparib, 400 milligrams PO/BID. And what we saw was that there weren't a lot of big safety signals, about 15% with autoimmune complications, all grade 1 or grade 2. But we did see some efficacy, and what we saw is about half the patients had some level of PSA decline, with the confirmed PSA response rate, however, of 12%. What we did see also by RECIST 1.1 measurements in those that had soft tissue disease is 29% of patients exceeded the 30% mark that one would count for a response. Of course, however, with confirmation, we saw a 7% confirmed overall response rate. We need to investigate why the discrepancy there, and some of that may be the way we're measuring response in these patients. In regards to the molecular analysis, we did Guardant 360 circulating tumor DNA, did not find anybody with a definitive homologous recombination deficiency, and we did whole exome sequencing in patients that had soft tissue available for analysis. Unfortunately, that was only 17 of the patients, and we found 1 patient with a BRIP1 frameshift mutation. We couldn't confirm that was biallelic alteration, so we didn't call it. Generally, we suspect that this was basically unlikely to be many patients with homologous recombination deficiency. We can't say for certain, but we suspect that most of the patients are homologous recombination proficient. We obviously have to do more work looking at microsatellite instability, tumor mutational burden, etc. But we think that it's promising enough and well tolerated enough that we're expanding this cohort of 42 patients up to 100 patients, and we're starting a randomized phase 3 trial called KeyLink 010, and that is a trial of patients who have received either abiraterone or enzalutamide for mCRPC, docetaxel for mCRPC. They will be randomized to pembrolizumab plus olaparib versus the other hormonal agents. So if you had abiraterone before, enzalutamide. If you had enzalutamide before, it will be abiraterone. Dual primary endpoints of overall survival and rPFS.